Hello, and welcome to episode 130 of Public Interest Podcast with your host, Jordan Cooper, where we interview politicians, activists, advocates, and others who seek to improve the state of the world. We're here today with Josh Rosenthal, Chief Scientific Officer and co-founder of RowdMap, also an Ernst & Young Entrepreneur of the Year. Josh, how are you doing today?
I'm doing pretty well, Jordan. How about yourself?
Excellent. The first question I'd like to pose to you is, what are you currently doing, or what have you ever done to advance the public interest, and why?
That's a pretty good question. So probably on the first side would be work with NCVHS, which stands for the National Council on Health and Vital Statistics. And that's the congressionally mandated public advisory board that serves the Department of Health and Human Services, specifically the secretary. And so it's a group that's around data access, meaning, and use, and that was founded when Todd Park was the chief technology officer of HHS before he went up to be CTO of the U.S. He said, hey, we want to put public data out there. We think good things happen when we put it out there.
Sorry, just for our listeners. Yeah.
Sure. Health and Human Services. Oh, good catch. The Department of Health and Human Services. So Todd Park was the chief technology officer of that. He went on to become the chief technology officer of the U.S. And he said, you know what? We should, A, put data out there in the public domain because we think good things will happen with it for research, for business, for communities. And B, we should really bring in a variety of people from academics to, kind of business folks to really help make sure that people can actually use this for a variety of different things. So that's probably one line around public good that I've been working and spending a decent amount of time on, is really helping put public data out there and helping people get access to it and use it. And the goal of that project isn't just to put data out for its own right. It's literally not only to improve healthcare, but really specifically to create transparency and visibility. And so it's kind of a particular take on it. It's really around using market forces to improve healthcare. And without getting too silly, that's one of the reasons we won the Ernst & Young Entrepreneur of the Year award, was because even though the business isn't a nonprofit, it's very much for profit, it really is about creating public and social good and market value at the same time, which for our day job means getting rid of low-value care. So not to go on too much, but like the thesis of what we're really working on, one is putting the public data out there, wearing the government advisory hat, that's great, and technical advice or ONC and things like that. But in the day job with RowdMap, we really focus on looking at this 30 cents of every dollar spent that goes to nothing. And that's not just waste or fraud or abuse. It's literally the Institute of Medicine, IOM, came out with a report a few years ago that says that 30 cents of every dollar goes to nothing, which literally means low-value care. And so it's not just fraud. It's if you have a problem and you seek treatment, in many cases you have options. And one of those options might be high-risk, high-intensity, high-cost treatment, and another might be low-risk, low-intensity, low-cost treatment. And the clinical outcomes are the same. The classic example of that is back pain or lower back pain, not if I've been in a car accident or have acute thrombosis, but just if I have general discomfort. Like myself, I can lose a few pounds, my back kind of hurts a little bit. I have some choices. I can do some physical therapy for $6,000. I can have a specialist do a decompression and tap on my back with a little hammer for $16,000. Or I can have an orthopedic surgeon glue my back together with an epoxy called a spinal fusion for $60,000. The clinical outcomes of those are all the exact same. And so the question would be, why would you have people doing the $60,000 treatment? That's much more risky and has a bunch of clinical downside. And the answer is, in the economic model, for the longest time, they got paid to do that. So for the longest time in the academic world, the folks at Dartmouth, Atlas, or Unwarranted Variation, which are some of the folks on the team we work with, as well as just in general research, the Institute of Medicine study have known this. There are clinical definitions of what's high and low value. The problem was we never had data to actually look at everyone. And so the researchers that talk about that as being probably the single greatest challenge to the public and social delivery and impact of healthcare. If you literally got rid of that 30 cents that goes to nothing, that's an artifact of supply or artificial created demand from having too much supply, there'd be more than enough healthcare for every citizen. There'd be more than enough money to pay doctors, much more than they're being paid for doing the right things. And also there'd be more than enough money to have health plans be profitable to do it. Literally, instead of counting pennies on Q-tips, getting rid of that 30 cents. And the beautiful part about that is That's all publicly available definitions, what's appropriate, what's inappropriate, that back pain example, for example. And now finally, HHS, Health and Human Services, has put out the data. So that's what we do in the day job. We literally help providers and health plans do appropriate levels of things or high value care. And the researchers, like folks like Atul Gawande, I mean, they've really come out of the academic shadows of talking about this and into more of the mainstream. Gawande wrote a little article in the New Yorker of all places talking about, an avalanche of unnecessary care, killing patients in their pocketbooks. And basically he kind of summarizes the literature and says, every citizen in the country on average spends tens of thousands of dollars on care that they don't need, tests they don't need, things that don't make them better, that in fact many times make them worse. And the researchers summarize this as physical toxicities, taking money out of food, clothing, and shelter. So all that to say, in terms of what have we done from the public good, in the side job, I'll advise Department of Health and Human Services to make sure the data gets out and people can use it, et cetera, et cetera. And as crazy as it sounds, rather than just volunteering, we actually founded a business to literally get rid of that 30 cents and to be able to deliver the right care to the right people at the right time, using that public data and using those public definitions. So it's kind of one of those rare instances in healthcare where it was like the promise of disease management once upon a time, where you get paid to do the right thing. So that's what I'd like to think we do. Is that too technical or is that too fast?
That's, I think, just fine. I'll just define one acronym that you use, Josh. ONC stands for Office of the National Coordinator, which has to do with health information technology. I think one question that our listeners may be wondering is, what exactly is big data? What does it mean? What kind of information has the Federal Department of Health and Human Services been collecting? Why didn't they release it before? And what are you doing with it? How are you using that to find high value care? I think everyone's on board with the idea that waste is bad, but clearly the Institute of Medicine has known about this waste for quite some time. Why isn't everyone doing it? Why is there still waste? Why is it so difficult to comb through the data, and what data is there? What are you doing with it? What is RowdMap really doing with all this big data?
Oh man, that's like a great question. And just for the record, I mean, we're not the only ones doing it. Other people are doing it and trying to do it, and we hope that the entire industry does it. Honestly, it's one of those things where the more people get into it and focus on it, the better for everyone. So there's a couple different pieces to that. One is what is going on with the data and why haven't people used it, and what has the Health and Human Services put out. And then the other is kind of financially or economically, why haven't people done this? And from time to time, I guest lecture at places like Harvard or Hopkins or MIT, and it's, a mix of MDs and medical doctor students and masters of public health people, and even computer science and MBAs, business folks. And it's really interesting. Part of it is the talent is always really interested in the young people coming into the space, and they say, I want to be an entrepreneur, I want to do something cool, I want to do something disruptive in the healthcare space. And 9 times out of 10, they're focusing on an app or a piece of technology or something like that, which is interesting. But the average household spend in the U.S. is, $40,000-$45,000. And so that stuff is kind of on the edges. The real need and, frankly, the real action kind of goes through underserved and unprotected and, people with less access, Medicare and Medicaid. And a lot of that comes from kind of flyover states, so kind of the unglamorous, unsexy part. So all that to say, one reason nobody's tackled this is it sounds kind of esoteric. You sort of have to have some academic, chops to be able to do it. There's some data pieces. It's not nearly as cool as making a fat tracker app or something like that, right? So it's part of it. Mm-hmm. The talent from outside and venture capital and finance isn't looking at that in the same sort of way. It's not the sexy Internet of Things of healthcare, right? It's not Uber of healthcare, blah, 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 blah. The other part of this is you're absolutely right. These definitions we're using have been around from the Dartmouth Atlas of Unwarranted Variation for 30 years. One of the guys that one of the chief folks behind that, David Winberg's on our board of advisors, they've been doing that forever. And his father actually did the crazy thing, it was 30, 40 years ago, where he started looking at healthcare usage, and he said, hey, there's 10 times as many of these back surgeries on the other side of the river. I wonder why that is. The clinical need is the same, the case mix adjustment and risk is the same, but literally I have 10 times as many of these $60,000 surgeries. Why is that? And it turned out they had 10 times as many hospital beds. or 10 times as many orthopedic surgeons that specialized in that. And that's when he started to map that onto an atlas and literally say there's a geography of healthcare and there's a geography of demand. And essentially, Institute of Medicine came out as well and said we are oversupplied. When Patrick Conway, the chief medical officer of the Centers for Medicare and Medicaid Services, CMS, says, hey, the number one problem with fee-for-service, which I'll explain in a second, is the oversupply. So part of it was we always had the definitions. We never had the data. And so what happened when Todd Park came along is he set up in CMS, the Centers for Medicare and Medicare Services, a data shop. That was Niall Brennan and the Office of Product, and et cetera, et cetera. And they said, let's release some data. So they released not just a sample set that only researchers who write nifty letters on university letterhead get access to. They released PUF, or public utility files. And that literally means anyone can go and download it. You, your 10-year-old niece, your mom, your dad, whoever. Unrestricted use, which means you don't have to disclose in the same way. You don't have to daisy chain it. Anybody can go download it. The thing was, it didn't have patient information, but it did have provider or physician information. It literally identified the providers, their first name, their last name, what they did, their practice patterns, their unique identifier. And so they released that, and that covers 97% of the doctors, the physicians, the hospitals, the post-acute centers, everybody in the United States. So part of what happened with those definitions with Dartmouth and the researchers, it was always well known, but you could never get the data. You get a hospital system here, you could get a couple of health plans here, you could piece it together. But all of a sudden, CMS released this national data set that's 10 times larger than all of the insurers pooling their data together. And that changed everything. From a statistical point of view, it allowed – oh, sorry. Yeah, sure.
Just as context, I want people to know that though Medicare, first of all, covers primarily Americans age 65 and older, in addition to some other people below 65, but not too many. And Medicaid covers poor people. The reason why this data set that Josh is talking about with these public utility files is so important is that Medicare covers 1 in 3 American lives. So in a sense, it is the largest payer being a health insurance company in the United States. And so with 300 or so million Americans, this is data that covers about 100 million Americans. The reason why the data is so important is that it covers every geographic region of the United States and many demographic profiles. Of course, not too many young people, mostly an older population. But really the value here is that this data covers, this is the most complete data set pertaining to the American population that you could have. So that's just the context of why PUFs are valuable.
Oh, no, absolutely. And just also, that was the start, right? So that was nifty. They pushed out Medicaid and Medicare. And Medicaid, there's a lot more people on Medicaid than you might think there are nowadays for a variety of reasons. Then they released PUFs on commercial and PUFs on ACOs and PUFs on population health data. Then they repurposed old school data sets like BRFIS, which is the Behavioral Risk Factor Surveillance System, which literally outpredicts claims for risk adjustment. Winberg published that in 2015 in the British Medical Journal. So the point is there's several hundred data sets out there, the backbone of which is Medicare, and there's Medicaid, and there's Exchange, and there's ACO, and population health. There's all sorts of good stuff out there that basically, when you tie them together, cover about 90% of the U.S. population, which is pretty stunning. And so why that's so important is because we never had that sort of data. So rather than having to ask a hospital and the other reason why it's important is it's a government issue data release and benchmark. And so they're adding a layer of analysis to it. So they're saying, hey, hospital, you have more readmissions than you should have. You have more readmissions related to cardiology. You have more readmissions related to orthopedics. You have more readmissions related to X, Y, or Z. And you have readmissions related, post-discharge. So it's this whole layer of analysis where they're adding an index and a benchmark on it, where in the olden days, that was all private data, and private statistical companies would build their own models on top of it. Now CMS came out and released the data, but not only the data was a layer of interpretation on it, which is huge. And then the other thing about that data release that you kind of have to think is that it's public. So previously, if you dealt with health plans or providers, you kind of go back and forth. The plan would say, hey, provider, you're not doing a good job. And the provider would say, yes, I am. My data says so. And the plan would say, no, you're not. My data says so. But the beauty of these government data releases is that it's out there in the open so everybody can see it. And so it doesn't mean it's always perfect, but it's how they're getting paid today. So it kind of takes that out of the realm of academic debate. Should this be high value? Should this be low value? Well, this is defined as high value, and people are getting paid on it today. The health plans aren't paying on, these type of injections, or you shouldn't be doing these types of procedures. The definitions for that aren't just based on the government data, but based on the specialty societies' definitions themselves, which is pretty interesting. So on top of these data releases, a whole host of folks came out, such as Choosing Wisely, which is, backed by Academy of Health and an institute and literally 70 specialty societies that say, we are doing too much of this. So number one, there's a data release. We never had data, so that was massive. We were able to do it. And number two, why didn't this work 10 years ago? Because it was in the realm of academics. There's no financial incentive in the market for people to use it. And that's kind of what I was saying. It's really easy in healthcare to be financially profitable doing kind of questionable things. It's also really easy to do meaningful public and social good, but not to get paid for it and end up being a nonprofit. The trick is how can you actually create market value and use this? So there are never financial incentives for people to be interested in that. Now all of a sudden, as you move to kind of value-based arrangements, or you say, hey, I want to do population health, or either CMS, Centers for Medicare and Medicaid Services, move people away for fee-for-service, or the private payers move people away from fee-for-service, all of a sudden that high value and low value is incredibly meaningful. Just a word of context on that. So fee-for-service means I get paid more. I'm a doctor. I get paid more for doing more stuff. And I get paid more for doing higher intensity stuff. Why do I do the $60,000 surgery when the $6,000 PT treatment would have the exact same outcome? Because I make $60,000, so I'm going to do that. So the data really allows you to say, hey, it's the national average for people who should get that surgery in a geography is 5%. In Kentucky, where we live, it's 35%. In Louisville, Kentucky, the hospital referral region, it's 48%. With one particular provider group, it's 80-some%, and one doctor has over 100% of that. He's doing more of these than he has patients walking through the door. That's all.
So the takeaway. Sorry, with all those percentages, the takeaway is that there's a lot of different variation, right?
There's a lot of different variation, but it's driven by an economic model. The reason that guy does that is because he's quote unquote building his practice. So fee for service is an economic model.
Right.
Exactly. It's an economic model that creates artificial demand. So one, in answer to your question, there's two different reasons. One, we never had the data. Two, we never had the financial incentives. And so the financial incentives are really interesting. It's not just the payer saying, I don't want to pay for that $80,000 treatment when a $18,001 will not only work better, but potentially have a better clinical outcome and take less out of pocket of that person. But also the providers themselves are saying that. And we work with a number of healthcare hospitals and physician groups, from elite academic centers to folks out in the middle of, rural Mississippi. And they'll literally say, hey, we wouldn't do this unless we were paid to do this. Help us come up with a plan to transition. If we move to this value-based stuff for getting paid on the outcome or only getting paid on high-value care, then we need some data to know what we're doing and how we're doing. The easiest way to explain it to people who aren't healthcare related is to think Moneyball. You ever saw that movie or read that book, Moneyball? It's about
Brad Pitt.
Oakland A's.
Yeah. That's one. Yeah. Baseball.
Yeah, Jonah Hill's always my inspiration. But yeah, literally, little tiny Oakland A's don't have as much money as the New York Yankees. And so they start using this analytics, this particular type of processing information. The data was always out there. Every other team had access to the same information. They just looked at it differently. And the way they looked at it differently is they looked at it high value versus low value. So at the end of the movie, the Oakland A's, they only get as far in the playoffs as the New York Yankees. And the coach, Brad Pitt, is very sad. He says, we didn't get any further. And he's meeting with, a Red Sox owner offering him a job. And the Red Sox owner says, look, you won the same amount of games as the New York Yankees. You did it on $240,000 per win, and they did it on $2.4 million per win. You had the same amount of wins, but you did it at remarkably lower cost. You had better wins per dollar, better outcomes per dollar. And so that's what essentially the market is moving to, not just better outcomes, but outcomes per dollar. You can have a really good clinical outcome on a surgery you don't need. You can have a really good patient experience on a surgery you don't need. And you can have a low cost on a surgery you don't need, classic triple aim, but you still don't need it. And so just to polish off the question, one, there's never the data in a meaningful way that covered basically every American and every doctor. And number two, there's never a financial incentive in the same way. So now that's kind of taken the front seat. And the healthcare plans, for what it's worth, they used to control their risk or drive their profit off the demand side, which meant configuring the benefits and actuaries doing this or that. And typically it would be, these people can have this plan, these people can have this plan. But with more and more government programs and even more pushback from providers, they can't do that as much anymore. There isn't profit to be made there. So now all of a sudden they're looking over at the supply side, which is the physicians. And the physicians are sitting there saying, if you pay us the right way, we'll be happy to deliver high-value care. So from that point of view, it's really market forces driving patients and dollars to the people delivering good outcome per dollar. So I'm talking about dollars in finance, and it sounds very nasty, but even as I'll walk through in the lectures, if you're going to work in healthcare and you're going to deal with a whole bunch of people in a meaningful way, it means you have to deal with people who aggregate. And those tend to be bigger, publicly traded people. So the question is, how can you create a win-win-win where you get people the right care, you get docs paid the right way, and you get health plans paid the right way, which is kind of the trick.
So, Josh,
that's a lot to throw at you.
So some digestion, some context, some definitions, and I'll pose a question back at you. So what Josh is saying basically is that the combination of open access to massive amounts of data being defined as prices, provider, facility information, costs, all sorts of information about the finances of actually delivering healthcare, and then the financial incentive with value-based payments, which is increasingly incentivized both by policy changes at CMS, but also through incentives that drive those changes implemented through the Affordable Care Act, known as Obamacare. You have a desire to have better outcomes per dollar, which is a cultural and political issue that has actually been part of the American dialogue since really the 1970s, when Richard Nixon said that the cost of healthcare was just expanding too much and that they never wanted to see it get to 9%. Now we're at 18% of GDP being consumed by healthcare. Finally, a few other things here. Josh also used a term called ACO, which refers to an accountable care organization, which is an organization that consolidates providers and payers and health systems that basically takes on risk in the same, which is a product of the Affordable Care Act. He also spoke about Medicaid expansion, which is also at the discretion of state legislatures and governors, something offered through the Affordable Care Act, and mentioned a triple aim, which was introduced by Don Berwick, who's a former director of the CMS and the Institute for Healthcare Improvement out of Boston, speaks about reducing costs, improving population health, and improving patient experience. Finally, with all of that said and all that background out there, a question that listeners might have is, well, let me just ask you, Josh, what would you tell people who go to the doctor and they want something, right? A lot of times when they have that lower back pain, the best thing they can do is go home and put ice on it. But maybe you end up having patients who are advocating, give me a pill, give me a surgery. I don't want to have taken a day off from work to go see the doctor and just go home and basically put ice on it. What was the point of me paying for the doctor to basically tell me, let my own immune system take care of it, put some ice on it, and let the swelling go down? I want something to happen, so I feel like I'm getting something for my exchange. What do you tell Americans who are demanding and pressuring providers to give them services that they really don't need?
Man, that's a great question. That's also a good summary. That was a lot of stuff in there. I didn't realize I apologize. I kind of clipped along on all this stuff. And hey, just before I get to that, I just want to say on that GDP note, you're right. So 18% goes to healthcare. 30% of that by physicians themselves say is wasted. So you're literally wasting 6% of GDP. Like, think about that for a moment. And so this came out of Affordable Care Act, but it's not dependent on that. You know who really wants high value care? Health plans in commercial even. It has very little to do with the government side of it. They've just never taken the supply side and the physicians seriously because there's enough fat on the government, on the demand side of it through their pricing. Now all of a sudden the private health plans, even in commercial, having nothing to do with government programs, are saying, wait. You're telling me there's 30 cents and I can benefit my members? I literally can have this win-win-win where there's money for me, I drive patients and members to them. And that data, I should also say, isn't just pricing. It literally is the code level. So it's how they're practicing, how they're spending their time, which from a clinical research perspective is just mind-boggling when you start looking into that. So all that to say, yeah, what happens when a patient comes in, it's worse than that. They might not just be demanding it. If they're in an area and they happen to live in an area where there's too many hospital beds or too many orthopedists specializing in fusion, they may get a first opinion, says you need that back surgery. Second opinion, he'll say you need that back surgery. Third opinion, she'll say the same thing because you have that artificial demand. So what do? The first piece is that Choosing Wisely campaign is really interesting. That's Consumer Reports and all of the specialty societies, 70 of them, getting together and saying, hey, you need to have an informed conversation with your doctor. They basically admit, we do too much low-value care. So when you come into my office, and not only when you're asking it, you need to have a conversation that walks around, do I need this? Will I have a better outcome? Is there any science behind this better outcome? That's one piece of it. The second piece of it, we're trying to work on the supply side with RowdMap in my day job. I'm working with the health plans and providers directly. So we just funnel patients and members to the high-value ones, so that doesn't happen as much. We're trying to kind of handle it on the business-to-business side of it behind the scenes. On the consumer side, you have the Choosing Wisely piece, and you also have U.S. News and World Report. We're their official partner. They used to be very reputation-based, and now they've moved in to using this publicly available data for their rankings, and including low-value and high-value care. So looking at someone who's doing something along those lines would be very helpful as well. And the conversation, or the way to think about it is, yeah, my back hurts, you're telling me to put ice on it. The alternative is to basically say, do you really want me to glue your back together? You're going to be out of work for a long time. That's going to cost you a lot more money out of pocket than you think missing a day off is. And guess what? It starts to disintegrate after a couple years, and bad things happen. So that's kind of around the Choosing Wisely campaign, what questions to ask. If you want a more data-driven approach, folks like U.S. News. And then, honestly, rather than relying on the informed consumer, which if they're out there, that's great, and we encourage them, and that's why we're working with U.S. News, but we really try to work with the provider systems themselves, the systems handling. We, as RowdMap, cover over 100 million American lives in our client base, from patients and members. And the folks that work with us are really driving patients and dollars to the high-value ones. So our hope is that you get the right provider, not just the person who has the best clinical outcome, but the person who can do the best clinical outcome on the thing you need. So we're trying to handle it behind the scenes, but if you have an informed consumer, I'd say Choosing Wisely in U.S. News. Does that make sense? Of
course, it does. And you also have to take into account that the changing financial incentives put providers at risk for improved clinical outcomes, gives them the incentive to spend more time having that discussion with someone. Of course, it's much quicker for a patient to come in and say, I want this surgery or pill, and the provider who's going to get paid more just doesn't put up on a fight, gives them the surgery or pill, even if it's not helpful or potentially even harmful, as opposed to a provider being financially incentivized to spend 15, 20 minutes talking with that patient and having that discussion.
Exactly. So, that's why the back end, it's not like we're doing business to business to try to hide from the consumer, but it really is, you change complex systems by changing these kind of key touch points. And to your point, finances, it's not a dirty word. It's, can you actually align the money with doing the right thing? And in this case, if you can align that by paying them on the amount of high value care, all of a sudden they make more money if they deliver the appropriate thing. You're aligning the clinical outcome with their payment, which is, to your point, translates into, you may not know about that. You may be an uninformed consumer walking in the door. And our hope is, I hope you've seen Choosing Wisely. I hope you're prepared to have that conversation. I hope you've looked at the rankings in U.S. News. I hope you've done that. But if you haven't, I want that doctor to be incentivized to spend the 20 minutes with you and say, okay, you may want to be looking at this, but here's the unintended consequences and negative side effects, and here are these 3 alternatives that have the exact same kind of clinical outcome on that. And this means less out of pocket to you. It means further uptime. It means more time at work, and it means more money in your pocket for food, shelter, and education.
So, because ultimately, Josh, what you're talking about is nobody wants health care. What they want is health. They want to live long enough to see their grandchild graduate from high school or college, or their daughter get married. And healthcare is a means to that end, and often we can lose sight of that in the healthcare industry and just say, well, it's all about provision of healthcare. But when you have that discussion and you frame it for patients within the context of, look, you're actually not a patient. You're a person who happens to be a patient right now, and the goal of providing healthcare is to get you back to your life. And when you give them that kind of framework, and the providers are incentivized to frame the conversation that way, then you end up getting improved value, improved outcomes, and reduced costs, and improved healthcare delivery for those who need it, right?
That's the only way we've seen it work. There's a group called the Healthcare Transformation Task Force, and they're in DC, and they're composed of payers like Aetna and HCSC and providers like Trinity and Ascension and Dartmouth Hitchcock and SSM, and they came out with a couple white papers. We helped write them, obviously, and they literally said, hey, what's the criteria for pay for value, and how high value care metrics, and how should we pay our doctors based on high value care? So we work in 49 states with a third of American lives, right? And like the only way we've seen it work, you can say, hey, doctor, treat the person as a patient in your electronic health record, and maybe their EMR system tells them to do that, maybe it doesn't. You can give them a campaign. You can tell the patient, hey, you should be more informed. But literally when you pay that doctor more to sit down and take the time and do the right thing according to his or her own definition, that's the way we've found it to be effective. Not just our opinion, but seeing that in hard economic ROI in rural Mississippi to Los Angeles to Florida to Hawaii to Alaska to the middle of nowhere. Every scenario, like literally aligning economic incentives with the right delivery of care using public data. So there's no funny business, there's no black box, there's no arguing. That was one of the other reasons why ideas like this haven't worked, because the data hasn't been public. But when everybody's using it, when the payers and the providers are looking at the same thing from the provider's own definitions of what's high and low value, and the providers themselves are saying have a conversation with it, and we can walk in and show them the data and help create the incentives where they do sit down and take the time to have that conversation. Like a lot of good ideas fail in healthcare because of all the perverse incentives, one of which has been this economic model. Now we actually have, a fighting chance to kind of do the right thing. And the only way you make that sustainable in a complex system is by literally creating kind of economic win-win-win. And fortunately, that 30 cents out of every dollar, that gives us enough slush to play with where we can realign it. So we're still taking baby steps, but, for the listeners, there's 100 million Americans that are being managed by this right now.
So for our listeners, just real quick, ROI means return on investment. Josh, we are approaching the end of this podcast, and I'd like to ask you a final question. You mentioned that RowdMap is a for-profit organization, but you're trying to do good while you are actually making a profit. You've had a career in healthcare. You have many years ahead of you in your healthcare career. I'd like you to take a moment and reflect on what you think your legacy will be, what you would like your legacy to be of your involvement in the healthcare industry in the United States, how your work is advancing the public interest. And we haven't gotten into your personal life, but why is this so appealing to you? Why did you go into healthcare? Why is big data, which sounds to most people somewhat boring, so exciting to you? You're clearly passionate about this. What is it that personally has driven you to be an entrepreneur in the healthcare field within the realm of big data? And just why are you doing this, Josh?
Oh, man, that's a doozy of a question. Holy smokes. I guess I should have seen that coming, huh? Wow, so in terms of legacy, we'll probably just be a footnote out there. What I would like to have as part of a legacy is being the guy that helped release the data and make it public so that a whole host, 1,000 flowers can bloom on it, right? There's 1,000 other roadmaps that use this stuff. And they literally, like in my mind, the single greatest problem with American healthcare is we're wasting 30 cents because we've created a perverse economic model and we've let it run for 30 years and we tell people to change it. And so now we have the incentives and now we have the data. And so the question is, who's going to do anything about it? That's actually, we run an institute here a few times a year. We bring in providers and some government folks and some payers, and they literally walk through how do you run healthcare as a business around it. And so on the financial side, unapologetically for profit. When I do the lectures at those places, it's very easy to be a 501c3. The question is, how can you create market value and do public and social good? I don't see those as mutually exclusive spheres of influence whatsoever. And there's different models for it, right? Like Todd's, the shoe company, says, hey, you buy our shoes, we'll give away a percentage. Okay, great. Warby Parker, they take a different approach. Their social and public good is tied to their product. You buy a pair of eyeglasses, and they donate a pair of eyeglasses, which have this cool, innovative feature that literally you change the compression for it with a screwdriver. So they donate them to Africa. They've given away more than any NGO. So so that's interesting. And we're trying to unite it even more closely. We're saying we only create profit when we realign, when we pay the right doctors to do the right things. And if we can do that, then, I mean, that'd be a nifty little legacy. In terms of kind of why we do it, it's a really good question. I sort of got outvoted. My wife is by far my superior and the brains and gravitas. She's our CEO, and our third partner, Barack, says, and Melanie and Barack, we've done a series of companies and taken them along in various places. And I want to do gambling or horse racing or something. We're in Kentucky, but they want to do healthcare. No, it's a joke. The basic idea is like when you look for where can you do something meaningful and literally impact people's lives. Like, I think it's a tragedy that guys walking in and says, hey, my back is a little bit sore. Somebody says, you need a fusion. They're going to shoot him up. He's going to miss work, money out of his kid's college tuition. And 2 years later, there's concrete breaking down in his back, all because we had a policy that said pay him more for that, and we never shared the data. That's mind-boggling to me. Like, where would we be at if we had that 6% of GDP in our pocket? And so that's literally part of it. Where can you actually do good? The trick is, and the real trick behind it is, how do you do it in a complex system? How do you do it with people with perverse incentives sometimes and mutually exclusive incentives? How do you essentially trick them into doing the right thing? And so that's a nebulous ethical proposition. And the answer is you use public data as a shared platform and you align their interests through finances. And so that's why we're passionate about it, I suppose. And is that a good answer?
So that's a great answer, Josh. So that has been Josh Rosenthal, Chief Scientific Officer and co-founder of RowdMap, Ernst & Young Entrepreneur of the Year, who speaks about trying to present public good and market value simultaneously through his work. He makes a profit by basically incentivizing people to do the right thing. He's frustrated by a world in healthcare that is not fair, it is not efficient, it is not logical. He'd like healthcare in the United States to be more logical, more fair, more efficient. He humanizes us. He knows that big data, we're talking about millions, billions of data points, but he sees individual lives. He sees dads who are paying too much money for care they don't need that's actually hurting them and preventing that money from going into their kids' college funds. He sees the human implications of big data, and what he does is he translates data in order to make it financially viable, which in the healthcare world, a lot of behaviors, as he described, are really driven by the almighty dollar, and he's trying to create a narrative and create incentives such that healthcare becomes more logical. And in fact, as giving examples that he gave of different benefit corporations, B Corps, he speaks about, look, if you really want to make a lot of change, you do a lot of good while making a profit, and you make it profitable for other people to do good, and you remove disincentives. Everyone wants to do good, but also has to get by. And for Josh, public service is about being at the forefront of this new economy, these major transitions in American healthcare. And really, regardless of what happens with the Affordable Care Act, he lets us know that a lot of these transitions are market-driven. They are driven by the private sector, and a lot of this will go forward regardless of where the federal law is. So Josh is somebody who's trying to make a more logical, fair, and efficient healthcare system that helps Americans, real Americans, improve their lives, their health, so they can better enjoy their own lives and pursue their own goals. Josh, thank you so much for joining us today.
Thanks a lot, Jordan. This was a blast. Keep up the good work.
Thank you. And that has been episode 130 of Public Interest Podcast with your host, Jordan Cooper, where we interview politicians, activists, advocates, and others who seek to improve the state of the world. Remember to subscribe at publicinterestpodcast.com, listen on iTunes or your podcast app on Apple products. We're also on SoundCloud, Blueberry, Player FM, Facebook, Twitter, and Stitcher. If you'd like to leave a voicemail for Josh and communicate your concerns to him, call 240-630-0380, and your voicemail will be transmitted to Josh. Thank you so much for joining us, and we'll talk to you next time.